See important safety information at the end of the video.
Trialing is not really predictive of long-term intrathecal success. So any method which gets the patient exposed to the medication and does a follow-up and an assessment is technically fine. Single-shot methods have been described and have not been found to be superior versus catheter-based methods. Single-shot methods through a catheter have been attempted and not been shown to be significantly better than single-shot methods that are applied into the intrathecal space without the catheter. So in my mind, the trialing method is less important than the patient selection and the goals and therapeutic endpoint discussions that you have with the patient. The advantages of a catheter-based trial are that you can titrate the medication up and see if there are side effects that you will encounter. However, in my experience, most of the side effects that you encounter, things like pruritus, urinary retention, those things do fade with long-term intrathecal therapy in the first 4 to 6 weeks. Issues like pruritus and urinary retention, which can be distressing to the patient, are often not as big a deal when they're seen in the context of these things fade over time, and the therapy itself does not experience those issues whenever managed properly at low doses. We also don't find a significant need for dose escalation in the low dose therapy patients. In our study that we published in 2015, patients for 36 months maintained a relatively stable intrathecal dosing pattern between 150 and 300 micrograms throughout that time period. While there was a small increase in medication during that time, analgesia stayed relatively intact. Dose escalation is an interesting concept. So whenever you talk to the patient will always describe for you a need for more analgesia. And as I jokingly referred to a few moments ago, whenever I said pain control is kind of like money, everybody would always like to have a little bit more, and they think that it's possible to achieve happiness with greater income. You think you're able to achieve greater happiness with higher dose escalation. Many times patients ask for a dose increase, but they're not really having a pain issue or a functional decrement in their treatment. So whenever a person sort of casually asks, can I get a dose increase on my intrathecal pump? We will typically ask, what's going on? And whenever they say, oh, I just thought maybe I could get a little turn up today, we will comply with that, but we usually do a smaller dose increase of a 1 or 2% dose increase. What we have found in some of our follow-up studies are that whenever we dose increase at 1 or 2% or 5 or 10%, patients don't really seem to perceive a significant improvement on the 10% end versus the 1% end. They were just sort of asking casually, is there anything else that you can do? That's different from the patient who comes in and sits down and says, I just don't feel like this is helping me as much as it used to. For that patient, we create a very detailed and organized system in which we essentially retrial and reestablish efficacy. And it goes a little something like this. We sit down and we say, okay, you're not nearly as functional as you were. You don't perceive that your intrathecal therapy is helping you as much as it was. Let's create a series of weekly dose increases of a 10 to 15% range. We will do this without a tremendous amount of bother on your part. You'll come in, we'll say, are you still having the problems? Yes, you are. We will do the increase, and then we'll have a phone follow-up later in the week and see how you're doing. We will do 2 or 3 rounds of that until we either reestablish efficacy or efficacy is not reestablished. So if you're looking at the decision tree, if we reestablish efficacy, the dose escalation may be small, it may be medium size, but we've reestablished efficacy and the patient is happy. If after 3 or 4 rounds of prescribed dose increase, we don't reestablish efficacy, we then do a catheter side port study to make sure that everything is still working. Why don't we go to that immediately? Well, a lot of times we're able to reestablish efficacy in the vast majority of our patients with a little bit more aggressive dose titration. And it's important to keep in mind that that patient who says, I just don't think my therapy is working any longer or as well as it was is different from the person who just sort of casually asks, hey doc, could I get a turn up in my intrathecal pump today? Those are two different issues. But if you treat this casual request with the same intensity that you do the loss of efficacy request, then your dose escalation rapidly occurs over a course of a couple to 3 years, and you're having problems then with tolerance, and you're unable to reestablish efficacy. By utilizing this very systematic, algorithmic approach to dose escalation, we found that patients are actually able to maintain therapy at lower doses for quite some time and reestablish efficacy when they really need it and the times that they need it most.
Important safety information. The Synchromed 2 infusion system is approved for the long-term delivery of preservative-free morphine sulfate sterile solution and preservative-free ziconotide sterile solution directly to the fluid around the spinal cord for treatment of chronic pain. Targeted drug delivery should be considered after the patient has tried oral medications or other therapies that have failed or were associated with intolerable side effects. Implanting the system has possible risks, including infection, meningitis, spinal fluid leak, paralysis, headache, swelling, bleeding, and bruising. Pump or catheter problems can cause a patient to experience overdose or underdose and/or corrective surgery. Errors in inserting the needle into the pump refill septum during the refill procedure can result in medication being inadvertently injected into the pocket, resulting in an overdose that may be life-threatening or fatal. Drugs infused through the system may result in adverse events. Refer to appropriate drug labeling for prescribing information and detailed disclosure. Formulations not indicated in product labeling may contain neurotoxic preservatives, antimicrobials, or antioxidants, or may be incompatible with and damage the system. A prescription is required. Healthcare professionals must review the product technical manual and appropriate drug labeling prior to use for detailed disclosure. For complete safety information about Medtronic targeted drug delivery, call Medtronic at 800-328-0810 or visit Medtronic's website